Across fertility clinics, the same account keeps recurring. Women who spent years unable to conceive, starting a weight loss medication, and becoming pregnant within months. The pattern has a nickname: Ozempic babies. The biology underneath it is worth understanding precisely.
Hi, I'm Dr. Spandana, your OBGYN.
Let's define the terms first. GLP-1 receptor agonists, semaglutide, sold as Ozempic and Wegovy, and tirzepatide, sold as Mounjaro and Zepbound, were developed for type 2 diabetes and for weight management. Prescribing among women with polycystic ovary syndrome climbed from roughly 2% in 2021 to nearly 18% by 2025, a seven-fold rise in 4 years. Alongside that rise, clinicians began reporting unplanned pregnancies in patients who had previously been told conception was unlikely. Two separate mechanisms explain it. They are often confused. They deserve to be separated. Start with the ovary. Ovulation is regulated by a feedback loop between the brain and the ovaries. Adipose tissue, body fat, is not inert. It is hormonally active. It converts and releases signals that feed into that loop. Above a certain threshold, excess adipose tissue raises circulating insulin and shifts the balance of reproductive hormones. The loop is disrupted. Ovulation becomes irregular or stops. The epidemiology is specific. A body mass index above 27 is associated with roughly 3 times the likelihood of difficulty conceiving, largely because ovulation becomes less frequent compared with a body mass index in the reference range. So for many women, reduced fertility was never fixed. It was a downstream effect of a metabolic state, a state that can change. Here is the first mechanism. GLP-1 receptor agonists slow gastric emptying, increase satiety, and improve insulin sensitivity. The result, in trials, is a 10 to 15% reduction in body weight over 6 to 12 months. As weight decreases, insulin resistance eases. The reproductive feedback loop recalibrates. Ovulation returns. In studies of women with polycystic ovary syndrome, semaglutide restored ovulatory cycles in a majority of previously anovulatory patients, reported in the range of 55 to 75% across trials, and the timing carries a subtlety. Ovulation can resume before a regular, predictable period returns, which means a woman can be fertile in a cycle she has not yet learned to track. Contraception decisions made under the old assumption no longer hold. Now the second mechanism, and this one applies to a specific drug. The same slowed gastric emptying that supports weight loss can affect how oral medications are absorbed, including oral contraceptive pills, which dissolve and absorb in the small intestine. The evidence separates the two drugs. For semaglutide, controlled studies found no clinically meaningful reduction in oral contraceptive exposure. For tirzepatide, a single 5 mg dose reduced overall oral contraceptive exposure by about 20%. The manufacturer advises a backup, non-oral method for 4 weeks after starting the drug and after each dose increase. Two routes to the same outcome. Restored ovulation raises the chance of conception. Reduced pill absorption lowers the protection against it. For some women, both occur at once. This is where the information becomes practical. These medications are not advised during pregnancy. In animal studies, exposure during organogenesis was associated with fetal growth restriction and structural abnormalities at clinically relevant doses. Human data is limited but developing. A 2025 analysis in the BMJ of first trimester exposure did not find an increased rate of major birth defects compared with pregnancies in women with diabetes or obesity. Reassuring for inadvertent exposure, not a clearance for planned use. Guidance is consistent on timing. Because of the long half-lives, around a week for semaglutide, slightly less for tirzepatide, the recommendation is to stop roughly 8 weeks before attempting to conceive. For a woman not planning pregnancy, the same facts point the other way. A reliable, non-oral contraceptive method is a reasonable conversation to have when starting treatment. So, 3 points to carry. 1. Weight loss can restore ovulation, sometimes before periods normalize. 2. Tirzepatide can reduce oral contraceptive absorption. Semaglutide in studies does not. 3. Timing around conception is deliberate, roughly 8 weeks off before trying. The Ozempic baby is not a coincidence. It is physiology behaving predictably once the metabolic state changes.
For more doctor-explained videos on pregnancy, fertility, IVF, and women's health, subscribe and stay connected. Always consult your doctor for personal advice. Thanks for watching.